Excellent. Very good. So the title of the talk tonight is Review of the Precepts, Methods, and Effectiveness of Fertility Awareness-Based Methods. And the objectives are to present the science behind fertility awareness-based methods that are not normally covered in conventional training. I'd like to review the common types of fertility awareness-based methods briefly, and then discuss the success rates of using fertility awareness-based methods for avoiding and achieving pregnancy. So just a little bit about me. I spent 7 years training as a reproductive physiologist. I completed a postdoctoral fellowship at the Women's Research Institute, and then took my first faculty position at Louisiana State University Medical Center in Shreveport. That's where I directed the hormone assay, andrology, and embryology laboratories. And over a period of about 8 years in the IVF field, I had an increasing level of concern about the way the technology was used and how it affected the patient. So I left that field when I found alternative work. And I've since been trained in both the Creighton model and the Billings ovulation method. And I'm a passionate advocate for fertility awareness-based methods and restorative reproductive medicine. For the first part of this talk, I want to present the concept of the ovarian continuum, which is really the life work of Dr. James Brown. Dr. Brown was born in New Zealand, but then completed studies and worked at the University of Edinburgh in Scotland. He's most known for his work describing the menstrual cycle using urinary hormone metabolites, and he had an extensive publication record. He's also been cited for having done over 850,000 hormone assays to validate the Billings ovulation method. And he was also part of Dr. Pincus's think tank team on development of the pill. He assisted with the early work of ovarian stimulation, which was subsequently used for IVF. And he assisted in the development of IVF in Melbourne, where he moved in 1971. He subsequently became a critic of the aggressive use of IVF, and he shared concerns about the long-term ovarian suppression caused by the pill and the health of the women who were taking it. So I'm going to present just a small part of Dr. Brown's work on the continuum. You can find really this compilation of his research published in Human Reproduction in 2010, free on PubMed Central. One of the amazing things about this publication is that Dr. Brown passed away 10 months before it was published. He had written it, but his associates, Dr. Adrian Thomas and Professor Len Blackwell, submitted it and made the revisions. So to make sure to bring everybody up to speed on the reproductive cycle, I'm going to review the events of the cycle chronologically. And but first, let me orientate you to this graph. The first section here are the structures of the ovary. The second section indicates the endometrium, whether it's proliferative or secretory, and the thickness of the endometrium. The next section indicates when the cervix is active. And the next section is the levels of serum LH and serum FSH, LH in blue, FSH in yellow. The next section is the urinary metabolites of estrogen in blue and progesterone or pregnanediol in yellow. And then the final section here are the observations that you would see that a woman would make that correspond with the cycle, the hormone levels in the cycle. So the first thing that happens at the end of the previous cycle is the estradiol and progesterone levels fall. the suppression of FSH and LH is then lifted and a new cycle begins. The hypothalamus tells the pituitary to increase production of FSH. It does this primarily through pulsatile release of GnRH, and during this time, the pulses are about 1 per hour. FSH then reaches the threshold level. If you look really closely on this graph, you'll see 2 small black lines. One indicates the threshold level of FSH, and the other indicates the intermediate level. There's not a lot of difference between those values, but it's enough to make changes in follicular development. So once the threshold level is reached, a few of the most sensitive follicles are recruited. This is the recruitment phase. These follicles then begin their rapid growth. Estradiol is being produced in increasing amounts. The FSH then rises to the intermediate level, which boosts the leading follicle towards ovulation. During this time, estrogen has a negative feedback on the hypothalamus. Then the continued rising levels of estradiol stimulate the endometrium. It's now in the proliferative phase. And the cervix also responds by producing mucus, and the woman would indicate this on her chart with the use of a white stamp with the baby, indicating fertility. Local factors are then produced by the dominant follicles, primarily from the TGF-beta family of growth factors. It suppresses the lesser follicles. So this is the selection phase. The granulosa cells then of the dominant follicle increases sensitivity to LH, becomes more sensitized. The high estradiol levels activate the surge center. So the GnRH neurons don't have receptors for estrogen, but the neurons that feed into the GnRH neurons do. And the ones that have been found to be extremely important, there are others, but a very important group of them are called the kisspeptin neurons in higher centers of the brain. So they are responding to the estrogen levels. And during this time, the GnRH pulse frequencies increase to about 2 every hour. And this favors the release of LH from the pituitary. So the pituitary releases then a surge of LH. It causes luteinization of the follicles. It begins progesterone production, and it starts the ovulatory mechanism. Approximately 36 hours after the beginning of the LH surge, there's rupture of the follicle, and then ovulation occurs. The ruptured follicle is then transformed to the corpus luteum, which produces both progesterone and estradiol. The progesterone changes the endometrium to secretory. It also affects the mucus by activating the pockets of Shaw in the vagina, causing a drying effect. If fertilization does not occur, the corpus luteum regresses after begins to regress after about 6 or 7 days. Then the estradiol and progesterone levels fall. FSH and LH suppression is lifted again, and menstruation begins in a fertile cycle very uniformly after about 11 to 16 days. So that's what a a perfect 28-day cycle would look like. But as we know, it's not always a perfect 28-day cycle, and there are many variants. Dr. Brown's work helps us to know when the variability is normal and when it is not. So ovulation is the main event, not bleeding, which, because it is recognized by all women, tends to be overemphasized. It's the timing of ovulation that determines the length of the cycle. Short cycles occur when ovulation happens shortly after menstruation, and long cycles occur when there is a period of anovulation prior to the ovulatory event. So if you look at this, the slide, you see the depiction of 5 different types of cycles. This particular one in the middle shows a short cycle because the fertile period started right after menstruation. Whereas this last one shows a much longer cycle where there was a period of anovulatory activity prior to the fertile period. So this is a graph that was taken from Dr. Brown's work. You'll see there's individual dots here. They represent individual hormone levels. This is urinary estradiol up here and urinary pregnanediol or progesterone down below. The lines represent the 10%, the 50%, and the 90th percentile of the levels. And all of these cycles it was essentially 61 cycles from 40 women, are all lined up relative to the peak of estrogen. So what you see here is that while the levels of hormones may vary from woman to woman, the patterns of hormones in a fertile cycle are remarkably similar. So the continuum of ovarian activity means that for most of her fertile life, a woman will experience normal ovulatory or fertile ovulatory cycles. However, when the woman normally experiences infertile variants of the ovulation during periods such as the approach to menopause, breastfeeding and weaning, and during periods of stress. During this period of time, the hormone patterns differ from a fertile ovulatory cycle, and also a woman, when they go off of hormonal contraception, may experience these same variants. So infertile cycles, cycle variants are not separate entities. So in infertile cycles, they're not separate entities, but they're a continuous gradation where they go from no follicular activity to some follicular activity, but no LH surge, so no ovulation, to an increasing maturation of the LH mechanism, meaning there could be luteinized unruptured follicles, there could be a short luteal phase or insufficient luteal phase, and then finally to a fully fertile cycle. And this commonly happens during menarche, during breastfeeding and weaning. If an athlete has been heavily training to the point where they are no longer cycling, and then she stops this heavy training, this will occur, this pattern will occur. And again, it also happens when the woman goes off of hormonal contraception. But the pattern can also go in the opposite direction, where a woman could be having fully fertile cycles. It'll progress to a failing LH mechanism where they're having short luteal phases or insufficient luteal phases, luteinized unruptured follicles, to having some follicular activity but no LH surge, and then finally to no follicular activity. And this commonly occurs during the approach of menopause, an athlete in intensive training. So cycle variants should not be considered abnormal. They are normal responses to the environment, ensuring pregnancy does not occur under unfavorable conditions for the mother and the fetus. But this can also happen, these variants can happen when a woman experiences some kind of metabolic or endocrine issues. And although this would not be considered part of the normal continuum, and it would need to be worked up. Cycles that are part of the continuum should not be considered abnormal again. And giving patients hormonal contraception during that time to regulate the cycle may be counterproductive. So when should the patient seek treatment? How do you know then whether it's part of the continuum? Well, Dr. Pilar Vigil from Chile has published that 3 or more abnormal cycles in a year, or 2 consecutive abnormal cycles, is when it's an indication that she needs to be worked up with a hormonal profile. And she describes an abnormal cycle as one that is shorter than 24 days or longer than 36 days, or that there's a normal cycle length, but there's a short luteal phase or ovulation has not occurred. Again, this would be when it isn't otherwise explained by the woman's stage of the continuum, meaning she's in menarche, she's approaching menopause, she's weaning from breastfeeding. These are all times when this would not be indicated as a health issue. So to drive home that point, I wanted to show a chart. Let me explain the parts of the chart here for those who are not familiar. So first of all, the green stamps here for each individual day would represent no cervical or vaginal discharge, so dry. Anytime there's a white stamp with baby, it would indicate some type of cervical or vaginal discharge, indicating fertility. And then anytime there's red, including the red dots, it would indicate some type of bleeding. So you can see also on this chart, normally we don't have it, but we happen to have the urinary hormone levels as well that correspond with it. So you can see here, blue is the estrogen levels in the urine, and you see a little rise or a little blip in estradiol. And that corresponds to this observation of a vaginal discharge. But then it goes back to infertility. And then it progresses to another little blip, this time a little bit higher, a little bit longer, results in, again, some cervical vaginal discharge. But there's no developing pattern, there's no peak, and there are raised estrogen with some spotting. We would call this bleeding not menstruation, we would call it breakthrough bleeding. Breakthrough bleeding happens when there is, the woman is in the proliferative phase and there are elevated levels of estrogen. So then her observations go back to dry and they progress on to another period of some cervical or vaginal discharge. But you can see that these observations here do not progress, do not develop. They stay the same the whole time. And also doesn't proceed to peak. And there are raised estrogens. The levels go back down And this results in some bleeding a few days later. This bleeding would not be considered menstruation because there was not a peak, there was not ovulation. We would call this withdrawal bleeding. But you can see if a woman wasn't charting, there would be no way to really know whether this was menstruation or not, whether she in fact did or did not experience ovulation. So then the cycle continues. We drop down to the next line. This is still the same cycle because there was not ovulation. Again, we see another little blip in estrogen, corresponds with some cervical vaginal discharge. And then we have this period of a changing developing pattern. It's a changing developing pattern ending in slippery. And then when that's followed by an abrupt change, the woman is able to recognize peak on that day of change. Also, you see that there was some bleeding during this period of raised estrogen before there was any progesterone released. So this would be considered breakthrough bleeding. We're able to know that she ovulated on peak day in this case because of the hormones. But when a woman is not also recording hormones with the Billings ovulation method, we know that she could have ovulated on peak day or day 1 or 2 after peak. That's again for the Billings ovulation method. Other methods have a different definition of peak. For instance, in the Creighton model, the ovulation relative to their definition of peak can occur a few days before up to a few days after. And then finally, there is menstruation that occurs about 12 days after peak, which is a normal luteal phase length. And it occurs along with a withdrawal of both estrogen and progesterone. So again, I want you to think about the value this data provides and how not knowing this can impact the woman, a woman that's not charting. And also if she subsequently sees a healthcare professional, what they're going to be able to tell from what she is indicating. So now I want to move on and switch gears and talk about the work of Dr. Odeblad on the cervix. Dr. Odeblad was born in Sweden. He was trained as a physician in gynecology. And it was written that he left his medical position at the University of Stockholm in Sweden because of the need to do abortions there, which he objected to. So instead of practicing medicine, he became a Rockefeller Foundation Fellow at Berkeley, where he went to study nuclear magnetic resonance, so NMR, from a lab that actually had earned the Nobel Prize in Physics in 1952. So he learned this new technology, and then he moved back to Sweden and he collaborated with a colleague named Gunnar Lindström. And together they were able to be the first to study cartilage and publish on it using NMR. And then he also completed a PhD in physics and did his dissertation using NMR to study cervical mucus. He later also used the light and scanning electron microscope to do many of the foundational studies on the cervix. So the important point that you grasp here is that there are many types of cervical mucus, and each type has a very specific function. So in case you're not familiar with the anatomy, the cervix is located in the lower part of the uterus. And this is what we're talking about here, this part of the reproductive system. The cervix is lined with cells that respond to estrogen and progesterone and produce mucus. So what I'm going to do next is I'm going to show maps of the lateral wall of the cervix of a 26-year-old virgin. This is from the work of Dr. Odeblad. Each color will represent a different crypt or a different type of cell that produces mucus. This first picture shows the location of the crypts in the cervix. For instance, in this particular slide, we see the indication of G mucus, which is indicated in red. And then the second picture is a map of the mucus content of the entire canal. So G mucus stands for gestogenic. It's influenced by progesterone. It's represented in red. It is present during low estrogen levels. Following menstruation, until about 6 days prior to ovulation, the G mucus plugs the cervical canal, causing infertility. So now we're going to move the picture of day -6, which is 6 days prior to ovulation. We're going to move that to the bottom. And we're going to bring up day -5, so 5 days prior to ovulation. You can see the canal is now converting to more yellow color with some green lines. The green lines are representing P mucus, and the yellow is representing L mucus. And the figures next to those are basically showing the pattern that you would see under the microscope if you took that mucus, put it on the slide, let it dry, and then observed it under light microscope. So the L mucus forms a structure that supports the other mucus types. It traps poor quality sperm, and it acts as a filter. It also locks good sperm into crypts as a way of preserving them for the most fertile period. I'm going to talk a little bit more about P mucus in a minute. So now you see days -4 to -2, and you can see how the canal is opening up. It consists mostly of the yellow L mucus, but also you can see the blue lines, those blue lines going through it representing S mucus. The S mucus stands for stringy, and you can see how the L mucus is forming the structure. The yellow L mucus is forming the structure which allows for the S mucus to form these channels. The channels provide a place for healthy sperm to be held and nourished until the peak of fertility. Then 1 day before ovulation, P mucus and enzymes from the proximal end of the cervix increase. P again stands for peak type mucus. It's the peak type mucus and enzymes liquefy the other cervical secretions, allowing for the release of sperm that are stored in those S crypts. And when it does this, it produces also the slippery sensation associated with peak fertility that the woman recognizes. And because it's being released from the proximal end first, it allows the sperm to be released and then directed towards the uterus. Then on day 0, which is a day of ovulation, you see the cervix is maximally dilated. And then up until 3 days after ovulation, The canal is still open, but it's beginning to narrow and fill up again with G mucus. So this time with what Dr. Odeblad called G plus mucus. And the only difference between the G mucus prior to ovulation and the G mucus during the luteal phase is that the G plus mucus has a higher quantity of immune type cells, which are designed to protect the early pregnancy from infection. And then finally, by the 4th day after peak, the cervix is closed again. So one more bit of information I'd like to show you from Dr. Odeblad. This is really what I call from the treasure files. It appears to have never been published, so I guess it would be categorized as anecdotal data. But it shows that as a woman ages, the number and ratio of the different types of crypts in her cervix change. So this first graph is showing that observations from a woman who throughout her whole life was never pregnant, but also she never used hormonal contraception. And you can see here when she was young, in her 15 years of age, she had higher levels of these types of cervical cells in her cervix, the G, the L, and the S. And most significantly, the S crypts, which again, if you remember, are the ones that create those channels in the cervix, so very important for fertility. You can see how they decline most significantly throughout her life. And then the next slide is showing a woman who had 4 pregnancies during her life, but also did not use any hormonal contraception. With her, you could see that the pregnancies kind of prolonged or rejuvenated the S crypts. And then about 5 years or so after the last pregnancy, her S crypts began to decline. And then finally, this is a graph from a woman who was never pregnant throughout her life, but also she was on hormonal contraception for 10 years. And you can see here, this indicates when she was on hormonal contraception. Started around age 18 and progressed to about the age of 28. So you can see in this particular case, how rapidly the S crypts, again, very important for fertility, declined much more rapidly. And if you show these slides side by side, this is the woman who was never pregnant and never on contraception. This is the woman that had 4 pregnancies and no hormonal contraception. You just pick an age here, let's say at age 35, this woman had about 35% of her cervix made up of S crypts. And then the woman who had 4 pregnancies had about a 60% of her cervix was made up of the S crypts. And then you compare the first woman to the woman who was on hormonal contraception for 10 years. And again, you just pick the age of 35. And you see that in the woman who was on hormonal contraception at age 35, she only had about 20% of her S crypts remaining in her cervix. Okay, so I'm going to switch gears now again, and we're going to move on to do a quick review of the different methods of fertility awareness or natural family planning. The best way to think about the different methods is to organize them by how they work or what they measure. The first one we'll discuss is the rhythm method. The rhythm method is what many medical professionals think of when somebody mentions natural family planning. So it was developed in the 1930s, and it uses calendar calculations based on the woman's previous cycles to estimate when the next fertile period is. So cycles, in order for it to be of use, cycles should be fairly regular to be able to project estimates accurately. It cannot be used in irregular cycles or during breastfeeding. Pregnancy rates for postponing pregnancy are higher, meaning it's less efficient, doesn't work as well. And it also involves more abstinence. And it's used less for conceiving. It's really unfortunate that many professionals think that this is what natural family planning is. So then we have the cervical mucus methods. The cervical mucus methods are methods that only use the mucus observation. It includes the Billings ovulation method, which was developed in Australia by John and Evelyn Billings, along with the work of Dr. Oda Blad and Dr. Brown. Most of that science was initially done, and many of the others have been built off of this science. It relies on the woman's patterns of fertility. And it doesn't require any finger testing of the mucus, any touching or finger testing. Then we have Family of the Americas. It was developed by a woman named Mercedes Wilson, who actually worked with the Billings. It's slightly different and doesn't have independent evidence backing it up. So no publications, scientific publications. The Creighton model was developed by Dr. Hilgers in Omaha. It is a more detailed method for describing the mucus. It does require finger testing, touching of the mucus. Some find it more complicated, but it's also tied to a whole system of medical protocols called NAPRO technology. And then finally, the 2-day method was developed in Georgetown, at Georgetown University, is a simple method. It tells the woman that she's fertile when there are secretions and not fertile when she is dry. And then there are the symptothermal methods. They include couple-to-couple league, Sensiplan, Symptopro, and Justice. The thermal methods use cervical mucus and additional information from the thermal shift in basal body temperature. So that's what that looks like. A woman records her temperature every day and notices a small shift in temperature, which is about 0.4 to say 1 degree Fahrenheit, which corresponds to the rise of progesterone. And this is what that temperature chart would look like. It helps to validate that ovulation did occur. And then there are the symptohormone methods. These include the Marquette model, FEM model, and the neofertility. The symptohormonal methods usually use other, in addition to the cervical mucus and temperature or temperature, they also use hormonal monitoring. Monitors or strips to measure the LH surge, estrogen, or progesterone metabolites in the urine. And then they correlate that with the chart. The technology continues to develop, and these types of technologies fit into the device industry called femtech. Femtech is expected to be about a $3 billion market over the next 20 years. And then finally, lactational amenorrhea method. It uses specific rules for how and when a woman breastfeeds to take advantage of the lactational anovulation and space her children. There are many apps that are out there that have been developed and tied to these methods. The most important thing to remember about apps is an app is only good as the method that it's being represented by. So if it's an app that's tied to a calendar method, then it's only going to be as good as the rhythm method or calendar method. So that's one of the important things. But there's more and more of these apps being developed, and they're becoming quite sophisticated. So now I want to give you some ideas on the success rates used for natural family planning, starting with for postponing pregnancy. Summarized data presented in this review article by Dr. Urotia I only pulled out the data for perfect use. Okay, so it gets more complicated when you start talking about what perhaps occurs when all women are using it because they make mistakes. But if you look at the graph here, the green bar represents the method Persona, which is a device and app method that measured urinary estrogen, also does LH testing. Pregnancy rates for it are reported as 12%. But excluding that method, the other methods range from 0 to 5% pregnancy rate for perfect use per 100 women years of use. So these are all the methods down below, and you can see these rates for perfect use, meaning that 95% effective. Okay, what about achieving pregnancy? What are the success rates for achieving pregnancy? This is a publication that was published in 2019 for the Billings ovulation method. It shows clinical pregnancies per participant as 3 groups. Couples who have been trying to become pregnant for less than 12 months. The infertile group between 12 and 24 months, so they meet the definition of infertility, which is 1 year of unprotected intercourse. And then the prolonged would be couples who have been trying to conceive for between 12 and 24 months. I'm sorry, more than 24 months. So you can see that the clinical pregnancy rate here is quite good, especially in the normal group, above 70% and above 50% in the infertile groups. But how does natural family planning and the method of restorative reproductive method compare to the IVF pregnancy rates? So let's explore that data a little bit. This is data pulled from the Society of Assisted Reproductive Technology, their national statistics that are reported every year. This is for the year 2018. Pulled this data off around the beginning of this year for some talks that I was giving. But this is live births per new patient. So it's live births, but it's multiple attempts at IVF. Some patients may have only required one. Other patients may have attempted more than one procedure, including frozen embryo transfer. And you have the different age groups, less than 35, 35 to 37, 38 to 40, 41 to 42, and over 42. This is for the age of the woman. So you can see that the live birth rate for the youngest age group is really good, fairly above 55%. Above 40%, maybe 42% or so for the 35 to 37. And then it drops off quite significantly with the age of the woman. This is data that was published by Boyle and colleagues in 2018. They were using the Creighton model and NAPRO technology. But this is also a group of patients that had already failed IVF. So it's a very challenging group. And the age groups here are pretty much the same as the SART data, except this last group here has been combined to over the age of 40. So certainly you can see in this challenging group of patients that the live birth rate for those patients less than 35 is about half of that age group in using assisted reproductive technology. Again, however, these are patients already failed IVF. But then you look at the next 2 age groups, 35 to 37 and 38 to 40, you can see about 37 and about 27. Actually not that much different. then the 35 to 37 using multiple IVF attempts, and the 38 to 40 age group, maybe just a few percentage points different. The other thing you don't see is you don't see that drastic drop off with the age of the woman. So it turns out, it appears that actually getting to the root cause can be quite effective, especially in older patients, or also patients that are very ill, have very serious issues related to their infertility. And then this is some data that was published again from that article in 2019 out of Australia for the Billings ovulation method. This is the infertile group only though. So this is the data from patients who have been trying to conceive between 12 and 24 months. First thing I want to point out, this is not apples to apples. This is clinical pregnancy rate, not live birth rate. And also these age groups are different. This first group is less than 30 years of age, and 30 to 35, and then greater than 35. But you can see quite substantial pregnancy rates here. Greater than 70% for the youngest group, about 50% for the 30 to 35, and still above 30% for the oldest age group. So because this data was published a little differently using clinical pregnancy rates, I reached out to the authors and got some additional information from them. Several of the couples had previously gone through infertility treatments, such as surgery and medical treatment. So it also includes restorative reproductive medicine. This is not just the natural family planning by itself. And some of the patients also went through assisted reproductive technology. In those specific patients, the pregnancy rate was 32% for those who have previously failed assisted reproductive technology. 85% of the pregnancies were achieved with using the Billings ovulation alone, 10% with also additional hormone monitoring, and then about 5.5% used fertility drugs, primarily Clomid. They were able to document live birth in about 70% of the pregnancies, and they documented a 13% miscarriage rate. They did lose 10% to follow. So this is a very crude way of trying to make comparisons now. This is the data from that last Billings publication that I just presented, but it takes into account that 13% miscarriage rate. So if you subtract that from the pregnancy rate, you're estimating live birth rate here. And then this is the SART data for multiple attempts to IVF. So because the age groups are different though, these two groups would be combined and compared to this group. So take 60 and 40 compared to 55.5. So if you estimate that that's, you average these, it's very close. And then of course, this group pregnancy rate would compare to all four of these groups combined. So the data I just presented demonstrate that natural family planning, along with restorative reproductive medicine, the rates for pregnancy are similar to assisted reproductive technology for achieving pregnancy. But to be fair, is there ever a time when IVF is clearly better? And I can think of a couple reasons, or a couple of reasons for infertility. That could be possibly severe male factor or blocked fallopian tubes. It'd be hard to argue, for instance, that you could match the success of, say, testicular biopsy and ICSI for an azoospermic man, for example, or for a woman with non-operable bilateral tubal occlusion, or a woman that no longer has her tubes because of previous ectopic pregnancy. Although, if we did further research, we'd likely find more cures for these. And it's because of IVF that these things have been largely ignored for the last 40 years. So even if IVF in some cases can be more effective, though, should the decision always be based on the chance of pregnancy? Because there are other considerations, such as the health of the woman and the health of the child. Not able to get into that data, but there is clear evidence that both the health of the woman and the health of the child is affected. And there's epigenetic changes that can occur to the embryos. Could also, or should also consider financial and emotional costs to the couple, and then also the moral, ethical, and spiritual concerns for that individual, for those individuals, as well as society. The use of art should not be the only option when it comes to the treatment of infertility. There's a bonus with natural family planning, restorative reproductive medicine. You may be able to diagnose, treat, and cure infertility so the couple not only conceives once, but goes on to have several children. And also, the chart functions as a biomarker for health and disease of the woman as she progresses through her reproductive life. So here's a list of other organizations that I'd highly recommend if you don't already know about them. The first one is FACS. FACS is an organization that teaches medical students across the country kind of an overview of fertility awareness-based methods, similar to what I did today, but maybe in more depth. They also have an elective available that you can apply for if your program accepts it. Then the International Institute of Restorative Reproductive Medicine is an international group of professionals focused on restorative methods. There's the Catholic Medical Association, which is an excellent professional group of physicians who practice medicine within a highly ethical framework, as does the American Association for Pro-Life OBGYNs. And of course, I mentioned Dr. Hilgers, who's the inventor of NAPRO, and also Dr. Vigil from the Reproductive Health Research Institute. Both teach protocols, medical protocols, and especially Dr. Vigil provides clinical resources and support after taking her courses. Finally, I want to make you aware that our organization, BOMA, has received funding for teaching the science of the Billings ovulation method to healthcare professionals, both physicians and really all allied health. This includes a deeper dive into the science that isn't taught, similar to what we did tonight. Allows you to learn the details of the Billings ovulation method with an option to become a certified teacher. And it also, we also present from other clinicians the use of the woman's chart as a diagnostic tool. So scholarships are available to access this material online. It'll include live presentations and access to Billings trained practitioners. So if you're interested in any of the information that I presented tonight, the more information on the other organizations that I presented, just email me at Craig, C-R-E-I-G, at BOMA, BOMA-USA.org. And I look forward to being able to correspond with you about that. So thank you all very much. I'm going to stop sharing my screen now. Hopefully there are some people still on, but I'm going to stop sharing and see if we have any questions. All right, well, we do have 17 people still on, and here's one question from Tammy Vore. Did Dr. Odeblad provide any explanations as to why there was difference in the types of mucus secreting crypts between women who have been pregnant versus women who have used hormonal contraception. I'm not aware of how he interpreted it, but I'll take the liberty of interpreting it myself. And Dr. Brown actually alluded to this as well. The suppression of the cycle that occurs under a hormonal contraception. There appears to be, some benefit to cyclicity, the changing levels of hormones, especially during the very early stages of a woman's life. This can affect both her brain as well as her physiology. And I believe the pregnancy, again, the circulating levels of hormones are rejuvenating, if you will, to the stem cells that are active in the cervix. That would be my interpretation.